Hello, my name is Dr. Ziad Emarah, lecturer of medical oncology and hematopoietic stem cell transplantation, internal medicine department, faculty of medicine, Mansoura University. Today, we will discuss approach to a case with lymphadenopathy. My agenda today will be introduction, anatomy and definitions, cause of lymphadenopathy, diagnostic approach and evaluation, then finally summary and conclusions. First, we will start with introduction. In postnatal life, the bone marrow and thymus are the primary lymphoid organs in which lymphocytes develop. The secondary lymphoid organs in which specific immune responses are generated are the lymph nodes, spleen, and the lymphoid tissues of the alimentary and respiratory tracts. Lymphocytes are the immunologically competent cells that assist phagocytes in defense of the body against infection and other foreign invasions. The immune response depends upon two types of lymphocytes, B and T cells, which derive from the hematopoietic stem cells. B cells mature in the bone marrow and circulate in the peripheral blood until they undergo recognition of the antigen. T cells develop from cells that have migrated to the thymus, where they differentiate into mature T cells during passage from the cortex to the medulla. These are the differences between T cells and B cells. Immunoglobulins, these are a group of proteins produced by plasma cells and B lymphocytes that bind to antigen. One of the most striking features of the immune system is its capacity to produce a highly specific response. For both T and B cells, this specificity is achieved by the presence of a particular receptor in the lymphocyte surface. Antigen-specific immune responses are generated in secondary lymphoid organs and commence when antigen is carried into a lymph node on the dendritic cells. This is the structure of the lymph nodes. B cells recognize antigen through their surface immunoglobulin, and although most antibody responses require help from antigen-specific T cells, some antigens, such as polysaccharides, can lead to T cell independent B cell antibody production. In the follicle, germinal centers arise as a result of continuing response to antigen stimulation. So, if we have chronic antigen stimulation, the lymph node may recruit a lot of cells and then enlarge. My second part will be the anatomy and some definitions. Normal lymph nodes are usually less than 1 centimeter in diameter and tend to be larger in adolescent than later in life. Lymph nodes are often palpable in the inguinal region in healthy people, perhaps because chronic trauma and infection is so common in the lower extremities, and may also be palpable in the neck, particularly submandibular following head and neck infections, usually in children. Lymphadenopathy is a term meaning disease of the lymph nodes. However, almost used with swollen or enlarged lymph nodes. When the infection is one of the lymph nodes themselves, it is called lymphadenitis. But when the infection is of the lymph node channel, it is called lymphangitis. So lymphadenopathy means swollen or enlarged lymph nodes. However, lymph node enlargement may be considered normal if they are soft, flat in the submandibular regions and less than 1 cm in healthy children and young adults. Palpable inguinal lymph nodes of up to centimeter in diameter may be also enlarged without any pathology in healthy adults. These are the lymph node region in the body. We have cervical, and we'll discuss later. Then we have axillary, epitrochlear, inguinal, and popliteal. Supraclavicular lymph nodes may be considered a separate group or may be considered a group of the cervical lymph nodes. These are the anatomy of the neck. We have anterior triangle and the posterior triangle. Separated by the sternomastoid muscle. These are the lymph nodes of the head and neck. We have two groups, horizontal group and vertical group. And the horizontal group divided into superficial outer and deep group. And the vertical group divided into superficial and deep group. So what are the horizontal group? The horizontal superficial group are the submental group, which drain the lower lip, floor of the mouth, and apex of the tongue. Then submandibular group, which drain the cheek, side of the nose, lower lip, gums, and anterior tongue. Then preauricular group, which may also include parotid and tonsillar and jugular-digastric group. Post-auricular group, then occipital group. What about the inner deep horizontal group? It is a Valdayer ring. Valdayer ring consistent of tonsils. We have adenoids, 2 palatine tonsils, and 2 lingual tonsils. Valdayer ring. The vertical group are divided into 2 groups separated by the sternomastoid muscle. Superficial cervical, lower, which drains the lower ear and the parotid, and deep cervical, which drains other nodes of the head and neck, occipital, scalp, ear, back of the neck, tongue, trachea, nasopharynx, nasal cavities, palate, and esophagus. And we have also posterior cervical, the posterior triangle, and supraclavicular, which may be considered separate group because these lymph nodes groups have different drainage area in the right and in the left area. This diagram shows the drainage pathways of external lymphatic drainage and the internal lymphatic drainage of the cervical lymph nodes and the direction of the flow. Lymph nodes of the arm consistent of epitrochlear lymph nodes, then lateral axillary lymph node, then central axillary lymph node, then infraclavicular lymph node. We wanted to show more demonstration of the axillary lymph node groups. Usually, remember, lymph nodes are associated with the veins, in contrast to the sympathetic chain, which usually join the arteries. So most lymph node groups during dissection of surgery are dissected around the veins. So we want to show these groups of the axillary lymph nodes. We have lateral group, anterior or pectoral group, posterior or subscapular group, then central group, then go for infraclavicular, then supraclavicular. This diagram shows the axillary lymph node. We have lateral or humeral, pectoral or anterior, posterior or subscapular. Then all these 3 groups drains into central groups, then apical, then supraclavicular, then go to according to left or right or left subclavian lymphatic trunk. What about the lymph nodes of the inguinal regions? We have also two groups, horizontal and vertical group. Horizontal group along the inguinal ligament, which start from pubic tubercle to anterior superior iliac spine. Vertical group, we have also superficial and deep group. Superficial group along with the great saphenous vein, and deep group beside femoral vein in the femoral canal. Can we detect central lymph node enlargement? Although we cannot palpate central lymph node, but we could examine it clinically. First of all, mediastinal lymphadenopathy. We have a very important plane that start from sternal angle anteriorly to the space between dorsal or thoracic vertebra 4 and 5. This plane divides the mediastinum into superior mediastinum and lower mediastinum. If we have enlarged mediastinal lymph nodes, so through clinical examination and history taking, we can detect this enlargement. In history, the patient may suffer from mediastinal syndrome, which are dyspnea, dysphagia, and the hoarseness of voice due to compression of the recurrent laryngeal nerve. By examination, we may have unequal radial pulsation, and we may have positive Dyspin sign. Dyspin sign is whispering pectoralic below dorsal 4 vertebra due to enlargement of mediastinal lymph node. Another explanation of localized supraclavicular lymph node enlargement. If we have a localized left supraclavicular lymph node enlargement, this situation is called Virchow's lymph nodes. And the Virchow's lymph nodes indicate intra-abdominal malignancy. How this happen? This happen because we have on the left side thoracic duct, which drains the main abdominal trunk, cisterna chyli. So thoracic duct is extension of the cisterna chyli in the abdomen. So if we have intra-abdominal malignancy, that malignancy may be transmitted to the left supraclavicular lymph node, and by examination, if we found this situation in isolated, localized the left supraclavicular lymph node, this may indicate intra-abdominal malignancy. Don't forget to examine other lymphoid organ, for example, spleen, because spleen examination is one of the lymphoid organs. My third part will be what are the causes of lymphadenopathy. Lymphadenopathy can be caused by a vast array of diseases and drugs. A clinically useful approach is to classify lymphadenopathy as localized when it involves only one lymph node region, such as the neck or the axilla, and generalized when it involves more than one region. The location of lymphadenopathy can often be used to help identify specific etiology. For example, the cervical region, the anterior cervical lymph nodes are often enlarged because of variety of infections of the head and neck, or to some systemic infections such as infectious mononucleosis that caused by Epstein-Barr virus, cytomegalovirus infection, or toxoplasmosis. Supraclavicular lymph node is associated with a high risk of malignancy, especially in the left side. If we have isolated right supraclavicular adenopathy, usually associated with cancer in the mediastinum, lungs, or esophagus. In the left supraclavicular lymphadenopathy, as we mentioned before, Verkausen lymph nodes, suggest abdominal malignancy. For example, gastric, gallbladder, pancreas, kidney, testicles, ovary, or prostate. And we showed how this occurs. Axillary. The axillary nodes receive drainage from the arm, thoracic wall, and breast. Infection, including cat scratch disease, are common causes of axillary lymphadenopathy. In the absence of upper extremity lesion, cancer, usually breast cancer, is often found, especially in female. Epitrochlear. The epitrochlear lymph nodes are not normally palpable. So palpable epitrochlear lymph nodes are always pathologic. The differential diagnosis includes infection of the forearm or hand, lymphoma, sarcoidosis, tularemia, and secondary syphilis. Inguinal. Inguinal lymphadenopathy is usually caused by lower extremity infection, sexually transmitted disease, or cancer. So, what about the cause of generalized lymphadenopathy? Generalized lymphadenopathy may be caused by infections, cancer, lymphoproliferative, immunological, endocrine, or miscellaneous causes. We will discuss some of the most common causes of generalized lymphadenopathy. HIV infection. Lymphadenopathy is common in primary HIV infection. Usually present with non-tender adenopathy, primarily involving the axilla, cervical, and occipital nodes. During the second week of the acute symptomatic HIV infection, concomitant with the emergence of a specific immune response to HIV. Usually, lymph node enlargement occurred during the second week or the second phase of infection. Another infection is mycobacterial infection, TB. Usually appears in the neck, cervical lymph node enlargement in the neck. Lymph nodes are typically non-tender, enlarge over weeks to months without prominent systemic symptoms, and can progress to mating and amalgamated. Third cause, infectious mononucleosis. Classic infection mononucleosis is characterized by triad of moderate to high fever, pharyngitis, and lymphadenopathy. Lymph node involvement is typically symmetric and involves the posterior cervical more than the anterior chain. Lymphadenopathy may also be present in the axillary and inguinal areas, which helps to distinguish infectious mononucleosis from other causes of pharyngitis. Nodes are kidney-shaped and may be large. Lymphadenopathy peaks in the first week and then gradually subsides over 2 to 3 weeks. Other infectious causes may be caused by fungi like histoplasmosis, coccidiomycosis, cryptococcosis, usually in immunocompromised patients. Protozoal like toxoplasmosis and leishmania. Finally, spirochetes like secondary syphilis and Lyme disease. Malignancy. Usually squamous cell carcinoma metastasized to the lymph node, in contrast to sarcoma, which usually have hematogenous spread to the lung. So usually the metastatic carcinoma metastasized to the lymph node. Lymphoma. Hodgkin or non-Hodgkin lymphoma may present with painless, firm peripheral lymphadenopathy, although most patients with Hodgkin lymphoma present with neck lymphadenopathy. So Hodgkin usually present with lymphadenopathy more than non-Hodgkin lymphoma. Waxing and waning of peripheral lymphadenopathy may represent indolent lymphoma, like follicular lymphoma. Many patients with lymphoma present with isolated adenopathy on examination. Other sites of nodal involvement may be identified on subsequent imaging. Leukemia. We have 4 types of leukemia. All 4 types can cause lymphadenopathy. The most common is chronic lymphocytic leukemia, then acute lymphoblastic leukemia. Acute myeloid leukemia may be presented with lymphadenopathy if the patient has M4 or M5 type. Chronic myeloid leukemia may be presented with lymphadenopathy if patient progressed to blastic crisis, especially lymphoblastic crisis. So all types of leukemia can cause lymphadenopathy. However, the most common is CLL, then ALL. What about immunological and autoimmune disease? For example, systemic lupus erythematosus. Enlargement of the lymph nodes occurs in approximately 50% of patients with SLE. The nodes are typically soft, non-tender, and discrete, varying in size from 0.5 to several centimeters, and are usually detected in the cervical, axillary, and inguinal region. Lymphadenopathy is more frequently noted at the onset of the disease or in association with an exacerbation. Lymph node enlargement can be also the result of infection or a lymphoproliferative disorder in SLE. When infections are present, the enlarged nodes are more likely to be tender. What about the miscellaneous causes? Sarcoidosis. Sarcoidosis most frequently involves the lung. Up to 30% of the patient present with extrathoracic manifestation of sarcoidosis. Peripheral lymphadenopathy is present in up to 40% of patients. Patients with sarcoidosis are also have lymphadenopathy seen in imaging, most often hilar and or paratracheal mediastinum. Common presenting respiratory symptoms including cough, dyspnea, and chest pain. These are frequently accompanied by fatigue and malaise, fever, and weight loss. So, to simplify this large number of causes, we can say that antibody reaction in the lymph node can cause lymph node to be enlarged. So all of these foreign antigens, like external, for example, infection, or internal, like malignant cells, can cause lymphadenopathy. Drugs. A number of medications can cause serum sickness that is characterized by fever, arthralgia, rash, and generalized lymphadenopathy. Phenytoin can cause generalized lymphadenopathy in the absence of serum sickness reaction. So we have large number of drugs, for example, phenytoin, carbamazepine, atenolol, allopurinol, all are common drugs used in clinical practice. The fourth part of my lecture is diagnostic approach evaluation. A history and the focused physical examination will most often lead to differential diagnosis of peripheral lymphadenopathy, which will then inform the need for further evaluation. For example, laboratory evaluation, imaging, and or biopsy. History. The history in a patient with lymphadenopathy should focus upon the following. Age. Young age. Most common causes are TB, syphilis, or primary malignant lymphoma. Old age usually present with secondary metastatic carcinoma. Occupation. For example, brucellosis, usually associated in patients who have direct contact to cows. Patient may be also presented by localized signs or symptoms suggesting infection or malignancy. So we will put infectious and malignant cause in the differential diagnosis. Exposures likely to be associated with infection, for example, cat scratch disease, undercooked meat associated with toxoplasmosis, tick bite, Lyme disease, travel to areas with high rate of endemic infection, high risk behavior, for example, sexual behavior or injection drug use. Constitutional symptoms such as fever, night sweats, or significant weight loss suggesting tuberculosis, lymphoma, or other malignancy. Fever typically accompanies lymphadenopathy for the majority of the infectious etiology. Use of medication, past history that can cause lymphadenopathy. Foreign travel, which should extend the differential diagnosis to diseases that don't otherwise occur locally. The time course of the adenopathy also can help narrow the diagnostic possibilities. However, patients may not notice when enlargement first occurs, even in obvious places like the neck. So, in the complaint, usually patient may present with fever, sore throat, cough, fatigue, weight loss, increased night sweating, and the pressure effect, as we mentioned before in the mediastinal syndrome, dyspnea, dysphagia, hoarseness of the voice, pressure effect of the lymph node, especially mediastinal lymph node. History is the present illness. We usually should focus on duration, which group was first affected, is associated with pain or not, is associated with fever or not, is there any primary focus, is there an association of loss of weight and weight, loss of appetite and weight, are there associated pressure effects? Past history, usually past history of TB may be reactivation, syphilis, or any upper respiratory tract infection. Past history of recent blood transfusion. Past history of immune suppression, for example, corticosteroid therapy, any viral infection, any use of medication, as we mentioned before, phenytoin, cyclosporin, allopurinol, carbamazepine, or hydralazine. Family history. Is there any other member in the family diagnosed with TB, or any past or any family history of malignancy, for example, lymphoma? We have some cases with pattern diagnosis. Pattern diagnosis, it means special findings suggest specific etiology. For example, if we have patient lymphadenopathy with fever, so most common causes are lymphoma, TB, systemic lupus erythematosus, infectious mononucleosis, HIV. If patient has lymphadenopathy with petechial hemorrhage in palate in young boy with a cervical lymphadenopathy, this pattern diagnosis suggests infectious mononucleosis. If female patient present with axillary lymph node and a hard lump in the breast with ipsilateral lymphadenopathy, we suggest breast cancer until proved otherwise. Non-pitting edema with inguinal lymphadenopathy may suggest filariasis. If patient has constitutional symptoms, fever, weight loss, night sweats, and lymphadenopathy, chronic infectious causes, for example TB or HIV, or malignancy may be suggested. After complete history taking, we will go for physical examination. First, you should introduce yourself and take consent for physical examination, and put the patient in good position either for cervical, axillary, or inguinal lymph node examination. So positioning of the patient is a very important part. Then we should evaluate lymph nodes symmetrically from left and right side. This will help us in distinguishing enlarged lymph nodes in a given patient. It is important after identifying abnormal lymph nodes in one location to examine other locations to exclude generalized lymphadenopathy. General examination. During general examination, we may detect signs of malnutrition, which may indicate malignancy, anemia, jaundice, other lymph node sites, or edema. Remember, normal lymph nodes are not palpable. Don't forget to examine the draining lymph nodes area of any lesion, and don't forget to examine the area drained by affected lymph nodes. When you examine a patient with cervical lymph node, you should expose all the head and the neck up to the clavicle of the patient. If patient has axillary lymph node, patient should be stripped to the west. If patient has inguinal lymph node, umbilicus to the knee should be exposed. So we will start local examination of the lymph node by inspection. Remember 5S. Sight, or location, shape, size, surface, skin overlying, number, and pressure effect. Localized lymphadenopathy suggests local causes and should prompt a search for a pathology in the area of the node drainage. Although some systemic diseases such as plaque, tularemia, and aggressive lymphoma can present with local adenopathy, although systemic. Generalized adenopathy is usually a manifestation of systemic diseases. Size. Abnormal nodes are generally greater than 1 cm in diameter. In one series, no patient with a lymph node smaller than 1 cm had cancer, compared with 8 and 38% of those with node size from 1 to 2.25 cm and greater than 2.25 cm respectively. The term shotty is sometimes used to describe multiple small nodes but has no particular diagnostic significance. After inspection, we will go for palpation. The following points are to be fulfilled during palpation. Confirm your inspection. Check temperature, tenderness, consistency, mobility, special signs, for example, pulsation, transmitted or expansile, draining area, mated or not. Consistency. Hard nodes are found in cancer that induce fibrosis, for example, squamous breast carcinoma, and when previous inflammation has left fibrosis. Firm, rubbery nodes are found in lymphomas and chronic leukemias. Nodes in acute leukemia tend to be softer. Fixation. Normal lymph nodes are freely mobile in the subcutaneous spaces. Abnormal nodes can become fixed to the adjacent tissue, for example deep fascia, by invading cancers or inflammation in tissue surrounding the nodes. They can also be fixed to each other, mated by the same process. Tenderness. Tenderness suggests recent rapid enlargement that has put pain receptors in the capsule under tension. This typically occurs with inflammatory process but can also result from hemorrhage into a node. Immunological stimulation and malignancy. Cervical lymph nodes. These are the technique how to examine the lymph nodes. Usually in the cervical area we can palpate both sides at the same time. Remember, tender nodes suggest inflammation, hard or fixed nodes suggest malignancy. This is the technique for examination of the submental lymph node. Usually supports the floor of the mouth by one finger and examined by the other finger. This is a technique for submandibular and supraclavicular lymph node examination, bilateral comparison at the same time. These are other techniques for cervical lymph node in examination. Examine from behind, examine from front. This is a technique for axillary lymph node examination, left side. This is the technique for epitrochlear lymph node examination, and this is the technique for inguinal lymph node examination. In the axillary group, push the lymph node against the chest wall, because the lymph nodes are soft tissue and the bone are hard, so you can palpate the lymph node easily. Epitrochlear have an inch above medial epicondyle. Compress the tissue against the humerus, then you could palpate the epitrochlear lymph nodes. After careful history taking and the examination, we may use imaging. Radiological tests can define node size and distribution more precisely than physical examination. Imaging tests are helpful if it is not clear after physical examination that there is lymphadenopathy and or to evaluate surrounding structure of abnormalities. Imaging by CT, computed tomography, ultrasound, Doppler technology, or MRI can help distinguish enlarged lymph nodes from other structures and define the pathologic process, especially cystic changes. Finally, we may use lymph node biopsy. The need for lymph node biopsy will vary depending on the suspected etiologies, based on history and the physical examination, and whether or not the peripheral lymphadenopathy is localized or generalized. Don't forget to go for lymph node biopsy after CBC, complete blood counting, because CBC may detect acute leukemia or chronic leukemias, and no need for lymph node biopsy. We may diagnose leukemias without lymph node biopsy. Finally, summary and conclusion. Normal lymph nodes are usually less than 1 cm in diameter and tend to be larger in adolescent than later in life. Lymphadenopathy can be caused by vast majority of diseases and drugs. The location of lymphadenopathy can often be used to help identify specific etiologies. A careful history taking and a focused physical examination will most often lead to a differential diagnosis of peripheral lymphadenopathy, which will then inform the need for further evaluation, laboratory evaluation, imaging, and/or biopsy. When history and physical examination suggest a non-malignant cause, appropriate testing may be used to confirm a suspected diagnosis. Patient in whom there is a concern for malignancy should have appropriate evaluation for malignancy. Peripheral lymphadenopathy without any obvious cause after the history and the physical examination present a diagnosis dilemma. Patients with localized lymphadenopathy can be observed for 3 to 4 weeks if there is nothing else in the history, physical examination, and the laboratory screening to suggest malignancy. Biopsy is appropriate if an abnormal node has not resolved after 4 weeks. The evaluation of patients with generalized lymphadenopathy without suspected diagnosis based on history and the physical examination should start with a complete blood count, chest radiograph, and the human immune deficiency virus testing. Thank you for your attention.